because the manifestations are often rapid and progressive, and other symptoms such as diarrhea and flushing are not present in this case. However, ectopic causes of ACTH-dependent Cushing syndrome cannot be completely ruled out. ACTH-dependent mechanism also includes pituitary corticotrophic macroadenoma and microadenoma. Pituitary corticotrophic macroadenoma was considered because of the other signs and symptoms of Cushing. It was ruled out because there was no mass effect, such as symptoms of increased intracranial pressure. Therefore, this was ruled out. Pituitary corticotrophic microadenoma was ruled in because of other signs and symptoms of Cushing present in the patient. There were no symptoms of hyperandrogenism present, but this was not sufficient to rule out this condition. Therefore, we are left with adrenal adenoma, pituitary corticotrophic microadenoma, and ectopic causes. And between the three conditions, pituitary corticotrophic microadenoma is the most common, as it is responsible for 2/3 of endogenous Cushing. The most prominent feature of hypercortisolemia is the upregulation of processes. Increase in gluconeogenesis results in hyperglycemia, which may eventually lead to glucosuria and polyuria, dehydration, and polydipsia. Hyperglycemia may also lead to increased insulin resistance manifesting as weakness. Increasing lipolysis results in central fat deposition and increasing subcutaneous fat breakdown that presents as striae. Increase in protein catabolism leads to muscle wasting, which results to weakness, increased plasma protein, creatinine, and BUN. The increase in lipolysis also increases free fatty acids in the plasma, causing atherosclerosis that may lead to hypertension. Since the patient is diagnosed hypertensive, the increase in sympathetic nervous response leads to activation of the RAS and adrenergic system, increase in myocardial contractility, and activation of vasodilatory molecules such as AMP and BMP. This leads to left ventricle remodeling, resulting to left ventricle hypertrophy and valvular incompetence. This then decreases myocardial contractility, leading to decrease in stroke volume and cardiac output, causing hypotension. Persistent hypoperfusion leads to deficiency of oxygenation to vital organs like the kidneys and heart, which leads to increased salt and water retention, increasing the systemic venous pressure and pulmonary capillary pressure, which may further lead to peripheral edema and pulmonary hypertension and edema. Pulmonary hypertension may lead to congestion and clinically manifest as tachypnea. Cortisol also inhibits connective tissue synthesis and repair, resulting to impaired wound healing, causing ecchymosis and skin mottling. Glucocorticoids also suppress TSH, leading to hypothyroidism. Another effect of cortisol is the increased secretion of acids and pepsin, which can lead to GI bleeding, causing the coffee ground material in the NGT, decreased RBC, and hematocrit. Very high levels of cortisol can result in binding and activation of mineralocorticoid receptors. Effects of this include an increase in blood pressure, excretion of potassium, and edema. Cortisol is said to have an immunosuppressive effect. Decreased inflammatory response is brought about by several factors, including inhibition of phospholipase A2, suppression of immunoglobulin formation, neutrophilic predominance, and suppression of histamine. Fibroelastic activity may also be inhibited, which results in decrease in local swelling and blocking of systemic effects of bacterial toxins. These could all produce immunosuppression, causing susceptibility to different infections, like vaginosis and intercurrent pneumonia. The possibility of tuberculosis must also not be excluded, since tuberculosis is very prevalent in our country. This disease should be highly suspected in patients who present with weight loss, fever, and pleural effusion. Therefore, for our final diagnosis, we consider multiple organ failure as the immediate cause of death and septic shock as the intermediate cause of death. For the underlying cause of death, we consider Cushing's disease secondary to pituitary corticotrophic microadenoma, to rule out cortisol-producing adrenal adenoma and ectopic ACTH-dependent Cushing's disease. So that is the presentation of our group. Thank you very much for your attention.